Hi all. We're going to get started. I'm just going to do an informal land acknowledgement because there was a slide, but somehow it got lost in the wash. So I just wanted to acknowledge that we're on the land of the Coast Salish people, and I particularly like to acknowledge the Achuapsh people, who are the people of the large lake, like Lake Washington. I walk over to the lake every day, and I think about these people and about the generations, as we're thinking about perinatal mental health, the generations of these people that have lived here and cared for this land in such a way that we are able to enjoy the beauty of this land to this very day, right? Like in all its drama, that's now sunny and it was just raining, and yeah. So wherever you are and wherever you're joining us from, think about the people that lived on that land before you, or maybe they were your people and have taken care of that land up to this day and stewarded it. So I thank those people, the Coast Salish people. And I want to invite Helen Jack up to introduce our panel. Helen Jack is an assistant professor in medicine and one of our global mental health core faculty, and just a lovely partner in all of this work. So you might have caught her talk earlier this year. If you didn't, it's on our YouTube page on the Department of Global Health. It's an amazing conversation about prison and mental health with Ben Danielson. Welcome.
Wonderful. Thanks, Leah. Welcome, everyone. I'm really delighted to introduce our 4th of 6 Global Mental Health Speaker Series event. I'm an internal medicine physician, so don't care for people who are pregnant, but I'm so impressed by those of you who do. And I'm just delighted to introduce this panel of clinicians, researchers, and implementers who are going to be sharing interdisciplinary perspectives on perinatal mental health, an issue that really has wide-reaching implications for pregnant people, people who have recently given birth, their children's family, and communities. And I think here to discuss the complex and nuanced set of problems and solutions that affect people in the perinatal mental health space, we have Dr. Amritha Bhat, a psychiatrist and associate professor of Psychiatry and Behavioral Sciences, as well as the director of Perinatal Mental Health and Substance Use Education and Research and Clinical Consultation Center here at the University of Washington. We have on Zoom Dr. Keshet Ronen, an assistant professor in the Department of Global Health, who researches primarily digital health across the US and Kenya. We have also on Zoom Dr. Ellen Maccio, a family physician and the Perinatal Behavioral Health Coordinator for Valley Women's Healthcare down at Valley Medical Center. And we have Mia Edidin, a clinical social worker and clinical director of Perinatal Support Washington. So I will now turn it over to Dr. Anna Larson, a postdoc in epidemiology and psychiatry and behavioral sciences, who's going to be moderating today's panel to kick things off with our discussants.
Great, thank you, Helen. I presume everyone can hear online. How about in the room? Good, okay, great. Well, it's my distinct pleasure to moderate today's panel. And to get us started, I'm just going to give a brief background on perinatal mental health to launch into the discussion. So perinatal mental health disorders are common. They're the most common complication of pregnancy and postpartum. And today we're going to use the term perinatal, which is really the period from pregnancy to 12 months postpartum. And so perinatal depression has a prevalence of about 10 to 20%, perinatal anxiety, a prevalence of 15 to 20%, and perinatal post-traumatic stress disorder has a prevalence of about 6 to 20%. And then there's a smaller group, but a very important group, about 0.1% of postpartum people who experience psychosis during this period. And these prevalences are pretty similar globally. They fall within this range in most contexts, but there are some contextual factors that put the prevalence and risk a little bit higher, which we'll get into in a moment. And so untreated perinatal mental health disorders have adverse mother-child and intergenerational as well as family impacts. For the pregnant person, perinatal mental health disorders are the leading cause of maternal mortality. and also can have other complications for pregnancy, as well as gestational weight retention, and increased substance use and smoking. And then for infants and children and even into adolescents, there are adverse impacts of adverse birth outcomes of preterm birth and low birth weight. These disorders can also impact parent-infant bonding. And then in later child and adolescent stages lead to developmental delays in emotional regulation and cognitive delays, as well as growth delays, and can even be an associated factor with adolescent depression. And then, of course, there are family impacts of adverse effects on partner mood or mental health, disruptions to relationships, and impaired family functioning. And so the risk factors for perinatal mental health are also multidimensional and extend from the individual level all the way to the societal level. So a few individual risk factors I want to highlight are individuals who are predisposed to perinatal mental disorders if they have lower educational levels, a history of mental illness, and also in adolescent pregnancies. And then in terms of interpersonal level, lower household economic status is a risk factor, experiences of intimate partner violence or domestic violence, and other indicators of low social support. And then on the community and societal levels, contexts that include high stigma for mental health disorders, or structural racism, poverty, and settings with violence and conflict also contribute to perinatal mood disorders. So the good news is that there are a range of evidence-based treatments for perinatal mental health disorders. And these range in intensity in terms of the interventions themselves, the platforms, and as well as the providers. And Leah, you can just click that next one. Oh, it looks like something happened, but you can just, yeah, keep clicking until it's full. Perfect. Great. Okay, so on the lower intensity level, there are some interventions that are self-administered, and those can include peer support or psychotherapies on the individual or group level. And increasingly, some of these interventions can be provided via digital solutions like mobile apps or text messaging interventions, and predominantly those are also offering peer support and psychotherapies. These can also be offered online and via telemedicine. And then higher intensity solutions are medication, which can be offered via telemedicine and in person, as well as some complementary and alternative medicine therapies. And I think we'll touch on today kind of the range of care models that go from a lower intensity level with prenatal providers providing first-line services such as mental health screening. And then these also go up in intensity. Some of our members today will discuss integrated perinatal mental health care, which is really a stepped approach that includes screening, mental health diagnosis, treatment, and ongoing monitoring, usually integrated into routine settings like primary care or maternal child health care settings. And then finally, there's specialty mental health services, which is the highest intensity option. So with that very brief introduction, I'll get our discussion started. And so thanks to Helen, we had a brief introduction into each member, but I'll open it by just letting them each, in their own way, bring to life what they do in this space. And so that can be some key projects you're working on, some roles that you take on in perinatal mental health, and really what does it look like for you to engage in this field. So I will start with Amritha Bhat.
Thank you. Thanks for that introduction. I'll share, I guess, what a work week looks like for me within perinatal mental health. I spend a few days a week providing direct clinical care to patients experiencing perinatal mental health conditions. So, top of that pyramid that you saw, specialty mental health, and providing consultation to other providers who are caring for perinatal mental health conditions. And then for the rest of the week, I try to put myself out of that job that I do for those few days of the week in the sense of collaborating with obstetricians, midwives, doulas, primary care physicians, family physicians, in trying to get the best quality of perinatal mental health care to patients where they would like to receive it and the kind of treatments that patients would like to receive. So many patients prefer to receive their mental health treatment from their OB provider within their prenatal setting, and Dr. Maccio will talk more about that. And so I collaborate with prenatal providers in being able to deliver this kind of care. And then I also work on research and implementation projects and testing new ways of delivering mental health treatments.
Hi, everybody. By training, I'm a licensed clinical social worker, so I'm really a clinician and a therapist. I still do see patients, and so I'm providing support for mostly individuals. I also do some group work, which I really love. My role at Perinatal Support Washington, which is a clinical director, I'm overseeing our direct services. What that looks like is a lot of training, a lot of supervision, a lot of consultation for the various types of providers that we have, and our providers are peer. We have mental health providers, we have interns and folks that are in their graduate program really learning about perinatal mental health. And then my second role at Perinatal Support Washington is really overseeing our training program. And so similar to Amritha, we're working with lots of folks in Washington State and training a wide range of providers. We really think about our work as training anyone who's interfacing with parents and families. So we're not just training doctors or mental health therapists, but we're training, the front desk staff, we're training childcare providers, we're training home visitors in supporting everyone and building awareness around how each individual could support a family who might be experiencing perinatal mental health. So we work with lots of community partners around the state. And then the last thing that I'll say is we also focus on systemic and policy efforts. So things like extending Medicaid to 1 year postpartum, because we know that gives folks more access to mental health care, or thinking about reimbursement for mental health care for Medicaid reimbursement to try and increase access to care. So those are some of the things that I work on a day-to-day basis.
Great, and I'll invite Mary Ellen.
Thank you. So I am a family physician by training, but I joined an OB group about 20 years ago. And as some of you may be aware, mental health diagnosis and treatment is a core part of family physician residency training. But in contrast, OBGYN residency training programs don't typically include mental health as a focus or a core training objective. So when I joined this OB group 20 years ago, I quickly became the person that partners referred patients to for postpartum depression as we thought of it back in 2004. And of course, the field has greatly expanded over the 20 years. And then the number of patients, the volume of patients really exploded during COVID. So I was using the University of Washington perinatal psychiatry line all the time, calling the consultants for help with the high volume patients and high risk patients that our group had in 2020. And through collaboration with Dr. Bhat, developed a collaborative care program for our patients. So we have a very busy practice. We do about 2,600 deliveries a year. And since, as Anna mentioned, 20% of patients will have some perinatal mood disorder, that's a high volume of patients who need services. We rely heavily on what Mia's organization provides, but we also in our own collaborative care team address patients who want to be enrolled in the perinatal mood disorder integrated care plan. One of the most interesting things about my work in this area day to day has been the realization that we exist, our perinatal behavioral health team has patients as one of our constituents, but we're also working very actively to help the OB clinicians become more comfortable with addressing perinatal mood disorders. So it's very lively and meaningful work.
Thank you. And we'll go to Keshet.
Thank you. I'm happy to be here. Yeah, unlike the other panelists, I am not a clinician. I am trained as a researcher and an epidemiologist. So my work focuses on conducting research studies and providing training and mentoring to students and other trainees in this field. My research interests are focused on how we can promote access to evidence-based prevention and treatment interventions for perinatal mental health among marginalized and underserved communities. And so the methods that we use for that include sometimes digital interventions, so taking evidence-based interventions that maybe were designed to be delivered in person and adapting them to be delivered virtually to improve access. They also include non-digital approaches where we integrate mental health services into contexts that are more accessible, as mentioned by the other panelists. But my focus is mostly on the research side of it. Thanks.
Thank you. Those were great descriptions. And as you can see, we have some of the heroes in perinatal mental health within the stage on this panel today. So I think I'll open our discussion with a question that some of the folks in the room may be thinking. So, why are we talking about perinatal mental health and perinatal populations separately from general mental health? What are the aspects of mental health disorders and treatments that are unique to perinatal populations? So with that question, maybe I'll start with Mia.
I can give a really great example about this. So I went to social work school to become a therapist and was working at a community mental health agency for many years after graduate school. And I had gone to school specifically to do perinatal mental health work. So that's what I wanted to do. And then when I got to community mental health, I said, oh, this is the population that I want to serve. And they were like, well, is that on the child and family team or is that on the adult team? Right? Like where does the folks that we serve, where do they lie? Who's primarily responsible? And I think that it extends to, sort of the outside of the mental health world as well. Is it the OB? Is it the PED? Is it the psychiatrist? Or like who is supporting the individuals? So I think that this population can often get sort of pushed around into different different providers without anyone actually having a lot of specialization or expertise in what to do and how to treat it.
Sure, yeah, I'll invite Amritha.
I'll add that in addition to kind of being lost within the system, pregnancy and postpartum can make people nervous when there's a provider caring for someone that's pregnant or postpartum, in the sense of, will the usual kind of psychotherapy be the correct treatment for this person? Or is it safe to prescribe a medication that we would have prescribed if this person was not pregnant or lactating? So that's another reason why there's often a need for a unique system of care for these people with people with expertise in this area that can consult and provide recommendations for treatment. And I can add more, but
Okay, sure. Keshet, do you have thoughts on this?
Sure, yeah. I think kind of the flip side of what Mia talked about in terms of where does this fall is that it is inherently like it connects the health of multiple different groups, like in the perinatal period. I mean, this is always true, right? People's mental health affects the health of those around them, their children, their families, but I think particularly in the perinatal period, that interconnectedness is so core and so important. I think the other thing that I think is really interesting about this period is that this is a period of both high burden, as you talked about, Anna, but also high opportunity, because people in the perinatal period are really accessing a lot more healthcare. So I think that's kind of a nice mix of risk and opportunity.
So Mary Ellen, go ahead.
I think an additional factor that makes the perinatal population unique is the risk involved with disclosing symptoms of mood disorders. So for adults who are in general care, may be highly motivated because of discomfort with their symptoms to seek care or disclose what's going on. But in the perinatal population, there is fear, maybe fear or awareness that disclosing their symptoms or the degree of mood problems that they're having may label them as an unfit parent. It just requires a great deal more vulnerability and even I certainly have in practice see that even when we are screening routinely, some patients won't disclose, but are actually really suffering. And it takes time and it takes a relationship with the OB clinician before they're able to risk sharing what they're experiencing because of the stigma for how they will be seen, their fitness as a parent.
Great, thank you. Those were helpful. Any other thoughts on this topic?
Amritha, you might be able to speak to this, but I also think that there's a fear from providers on sort of, approaching or touching, not physically, but like supporting a pregnant person or someone who might be lactating or breastfeeding, that there's sort of this, I don't know how to do that. And so because they're pregnant or postpartum, there's an additional, I'm not sure what I'm allowed to or what I should do. So I'm not sure if there's anything more you want to add to that.
Yeah, I agree. And although we're making progress towards integrating screening and treatment for perinatal mental disorders into prenatal settings, prenatal care itself is so packed and busy. OB providers within their 20-minute visit need to take care of so many other things, weight checks and blood pressure checks and ultrasounds. And so to add another piece onto that can become difficult, both in terms of training providers, but also in being able to fit that additional piece into their practice. So that's sometimes a reason to need to call out perinatal mental health separately.
Great, thank you so much. Okay, so my next question, often, and we discussed as a group that postpartum depression or perinatal mental health disorders are characterized as coming from just hormonal fluctuations. Maybe they're characterized as baby blues. But let's talk more about what's really going on here. What are the main drivers of perinatal mental health disorders? What are the structural drivers? And what should we consider beyond hormones? Maybe I'll start with Keshet on this one.
Sure, thank you. So the U.S. Preventative Services Task Force recently put out a document kind of outlining the risk factors of perinatal depression and some of the evidence-based interventions for it. And they really highlighted kind of common risk factors, which are very similar to what you outlined, Anna, in your presentation. And I think, to me, it's very interesting when we look at this list, just how many of these are so clearly kind of structural and societal. So those risk factors include things like low income, adolescent pregnancy, single parenthood, recent intimate partner violence, a history of significant negative life events. Globally, we know that HIV status is associated with risk of perinatal mood disorders. And I think it's really important for us to kind of recognize that these are markers of challenging contextual situations that ideally should be addressed through sort of structural and societal changes, right? To better support people who are in these situations in the perinatal period. And so I think it's really important that we think about perinatal mood disorders kind of through that lens as really sort of a product of what it means to be pregnant and parenting in a lot of the contexts that people find themselves doing that in. So I'll stop there and hand over to someone else.
Thank you. Anyone have burning thoughts about this topic and want to chime in next?
Completely agree with Keshet. It's easy when someone's pregnant or postpartum, it's easy to say, oh, it's all your hormones. And I cannot tell you how many of my patients have that said to them. It's just your hormones, it'll pass, it's the blues. But there's much more to it than just the hormonal changes are a real thing. And there is a subset of people who are very sensitive to those changes in hormones, but they make up a very small proportion of what is causing perinatal mental health conditions. And structural factors, I wanted to also highlight family level factors like things like autonomy and agency and empowerment. Women and other perinatal individuals often do not have agency within the family structure or within the societal structure. You start, interfering with reproductive rights, for example, that can have such a huge impact on mental health.
I think that when you think about these structural factors as being sort of more sort of the kind of the risk factor or the cause for whatever experience that the parent is having, it's important because if we're framing this as sort of a medical model hormone issue, that something is happening right biologically to an individual, then how we actually would approach treatment or how we'd approach solutions is going to be really different. But if we're thinking about this as actually the biggest risk factors are structural, then how we approach it is going to be really different, right? We're not going to be taking only an individual one-to-one treatment approach. We're going to be thinking about all those different, contexts that person is living in, right? All the different circumstances and the things that are happening within their life. And then as folks here in this room are thinking about how we might touch this or how we might impact it, right? We can actually there's lots of ways to come at thinking about this issue, right? So addressing financial stability, addressing poverty, addressing racism, addressing, maternal health disparities are all ways that actually get at improving, emotional and mental health outcomes, right? So it's not just like a mental health approach that we need to take. It's really a pretty wide approach. And so then if you think about that, it can get really overwhelming really quickly. And then each of us can say, well, what can I contribute to this, right? Or what am I supposed to do when I'm actually sitting with a person in front of me who's experiencing all of these structural and systemic impacts, and I'm one person, right? So, but I think that it's important that we still hold that context and that we're all working at, in all those different levels to be impacting the folks that we're working with.
Great.
And
Mary Ellen,
I think,
here.
yes, I just what Mia had said, all of you, but really it just leads into what it's like, what I experience as a clinician, on a day-to-day basis, meeting with patients, being able to talk about the scope of perinatal mood disorders, letting individuals know you're not alone. In fact, this is the most common complication of pregnancy, and giving them a sense of the numbers of individuals who are affected, and holding that, even though you may not be bringing up all of those structural issues, holding that when you're with them, I think is important, because there can be a sense of self-blame. In fact, it's one of the questions that is, I think, answered most positive on the validated tool that we use in our practice, the Edinburgh scale. One of the questions is, do you blame yourself when things go wrong, even if it's not your fault? And this is the situation that most of our patients are in. The structure that they within which that they live in is really set up in such a way to make it very challenging to have adequate resources for themselves and their families. And this, of course, can contribute to high cortisol levels and all of the things that contribute to perinatal mood disorder. So it's challenging with patients to make sure that they don't blame themselves, and keeping that structural model in mind is key, whether it's said out loud or not. It's part of what you hold as a clinician when you're with patients.
Thank you. Those are great responses. So across this group, you all work in a diverse range of populations. Some of those are here in Washington State and some are internationally in other settings. I want to hear about what you think are the commonalities and differences in perinatal mental health in domestic settings and international settings. And you can speak to the burden, how perinatal mental health manifests, or the treatment approaches in various settings. And I think I'll start with Amritha, since I know you have projects domestically and internationally.
Sure, I can, well, one of the things that stands out to me in my clinical and research work is the fact that, this is, I think, a commonality. The fact that pregnancy and postpartum is, of course, an important life milestone anywhere in the world. And so I think many cultures have rituals that are associated with this milestone. And I'm familiar with the rituals in India and here in the US. There's a ritual called doing a month, which is where after delivery, the parent is allowed to rest and relax and do nothing but take care of the baby, and the whole family comes around to help with this parent and child. And then, things like baby showers are also rituals. Parenting classes can be seen as a supportive ritual. So there are very nice ways across the world in which the community comes together to support this person during pregnancy and postpartum.
I don't work globally, so.
I think you do. Keshet, why don't you speak to this, and Mary Ellen and Mia can think about some linkages they've seen or heard about through collaborations.
Sure, yeah. Thanks, Amritha. I really enjoyed your response. What I was thinking of saying is a little more dry, which is that I think specialist provider shortages are a universal truth, but I think the magnitude is pretty different in different contexts. So I think, anyone who's tried to get in with a therapist in the last 3 years in Washington knows how difficult it is to find providers. But in low and middle income countries, the degree of provider shortage is really extreme. So just kind of to quote some statistics, in the US, I think there's about 10 psychiatrists per 100,000 people in the population. In Kenya, for example, which is one of the places that I work, it's less than 0.2. So that's a 50-fold greater kind of scarcity of psychiatrists. And that's, pretty typical. It's sort of like in the middle for sub-Saharan Africa. So I think, when you're dealing with a provider shortage of that magnitude, I think task shifting, so moving some of these tasks to non-specialist providers is a priority, I think, everywhere, but I think particularly in these contexts where, having psychiatrists deliver care is just completely infeasible. So I think that's one observation I would make. Maybe I can just plant a seed for Mia and Mary Ellen to comment on, even if you don't do global work. Maybe you can speak about some of the kind of cultural, how cultural diversity influences people's engagement with care, or how people talk or think about perinatal mood disorders. I think we see that even within US communities, right? So maybe you can comment on that.
Yes, I in our patient population, particularly the Hispanic population, is very reluctant to see mood disorders as a valid issue, but particularly in the perinatal period. So that certainly, I think, is a factor. But in general, the stigma about pregnancy and postpartum being a time of joy and happiness, and having the courage to say, I know I'm supposed to be happy, but this is difficult. It's particularly acute in the patients who have struggled with infertility and used assisted reproductive technology to conceive and then experience anxiety or depression or mood disorder. So I do think there are, that difficulty of acknowledging perinatal mood disorder is common. I think as I have attended conferences throughout the United States, there's definitely a theme about who can and who will deliver care. I think we may be speaking about that more specifically in the next question or so, but you can't rely on psychiatrists to deliver care because of the paucity or dearth of psychiatrists, as you were pointing out, Keshet. So it really does need to get into the hands, in my opinion, of the prenatal care providers, midwives, OBs, family physicians. That is one way of delivering care. And then you mentioned, and Mia can probably speak to, just promoting care through doulas and other community members. So it's, I think, across the United States and globally, how to get care to pregnant individuals is a very common theme.
I have some comments, and then I actually have a question for some of my fellow panelists. But some of the things that I think about here in the US that we're really struggling with is this piece around who's allowed to do mental health care. And that's, credentialed, licensed, Department of Health, right, gets a say in that. And there's lots of hoops that maybe some people in this room are working towards. And I know that I did that. And I support a lot of folks on that path. But what we know is that communities have traditionally ways of supporting individuals that have largely been removed, right, by systemic racism and white supremacy. And that's a real lived experience here in the US that actually prevents folks from getting access to care because the knowledgeable folks in their community have been disenfranchised, or that knowledge has been taken and has been commodified. And now we get to call ourselves a lactation consultant or a mental health professional or a midwife when we know that these roles have been held by folks in the community long before anyone ever came up with the term mental health provider. And so I think we are going to get into this. What I think is interesting is thinking about, here we have this very developed, right, sort of like licensed credentialing model of, how we approach providing care, but really thinking about there's not enough. That system is not really working. It doesn't work for a lot of folks. A lot of folks will never access that system. That's not how they want to get care, right? They don't want to get care in an office in a sterile setting from someone who doesn't look like them, who doesn't speak their language, who doesn't understand their community culture. And so really thinking about, how do we approach this differently? How do we approach this with the knowledge that we have around what type of care people want? And what I think is this is happening globally on a different scale than it's happening here in the US, or maybe there's more opportunity to think about other ways of care, because here in the US we get very, very serious about who's allowed to do what, and individual providers, or I should say groups of providers, can get very competitive, right? So mental health providers who have gone through all of these hoops, as an example, don't want a bachelor's level therapist now be able to come in to provide the same level of care that they were, or even a peer, right, to do peer counseling that's going to somehow displace them. So there's some, systemic issues, but then there's also, right, the piece around how do we navigate within the systems that sort of pit us against each other as individuals and in fields. So that's what I would think about. The other thing that I would say is I was having a conversation with a colleague recently about, in the US, we think around 3 months is about the peak period where we might find folks are symptomatic. Doesn't mean that everybody peaks at 3 months, but we would find that most people that might be symptomatic around 3 months. And one of the things I was wondering is, we think about that here because there is a hormone issue, but there's also that 12-week, right, sort of like maternity leave. Folks are often going back to work after that if they have access to maternity leave. There's also that you've had, you know, several months of sleep deprivation and caring for somebody else and not caring for you. So like there's like this symptom burden that can really sort of add up. But I'm curious if that's the same globally, or if some of the like the differences in how we approach supporting families on a systemic or a policy level actually moves that around.
It's a great question. I don't have like a direct answer to that question. I think,
Wondering.
yeah, I think, and this kind of relates to another point I was going to bring up, is it's important to think about mental health conditions on a spectrum. Right, so there are definitely people who need specialty mental health, but a majority of people just need support that comes from their community, or even, you know, the postpartum rituals I was talking about. And so that's where it's important to not think that everyone who expresses some distress or has some symptoms of depression and anxiety needs to follow that complicated path in the system to receive mental health treatment. And I think that also kind of relates to the answer to your question, Mia, is the pattern of distress similar or different based on systemic supports? And I think if we think about not major depression, but if we think about distress, perinatal distress, which is equally important to address, then I think that would be, I think we will see an association with how much the community is supporting this person.
And when, right?
And how much and when.
When,
Yeah.
yeah,
And how.
yeah, yeah.
Any additional thoughts from Keshet, Mary Ellen on this topic? Okay, taking silence as a no. Okay, I'm gonna shift gears a little bit and ask you all to talk about how you found your way to the perinatal mental health field and what motivates you to continue in this space. I know there's a lot of trainees and students in the audience, and I think this will be helpful to them. Why don't I start with Mary Ellen for this question, if you don't mind?
Sure. So as I mentioned, I'm a family physician, and mental health awareness and diagnosis and treatment was an integral part of my training. But when I joined an OB group 20 years ago, my OB colleagues were not comfortable, and so they sent their patients to me, and it was really an increasing exposure to patients struggling with mood disorders that ignited my interest and commitment to treating perinatal mood disorders. In 2018, well, I think Keshet was mentioning preventative U.S. Preventative Services Task Force. In 2015, I think it was both ACOG and USSPTF recommended universal screening for perinatal mood disorders. And then as a group, Valley Medical Center decided to make screening mandatory or strongly recommended at the 6-week postpartum visit. And so that was in 2018, our group began formally screening for perinatal or postpartum depression. And so then the number of patients that my colleagues were sending to me really increased in 2018. In 2020, with COVID, there was just a real explosion, much more than I could handle. And so that is when we started our collaborative care program with the help of Dr. Bhat and Amritha Bhat and the AIMS Center. So it's really been exposure to patients and hearing their stories and really wanting to respond to the need in our community that's led me to this point of really, it's become a very important part of my work. I'd say central to the work I'm doing now.
Great, thank you, Mary Ellen. I'll go to Mia next.
Let's see, I was always interested in mental health and then had a position in college doing a peer support role that I was really interested in. I mean, I just really liked it. And then I had my own kiddo. I didn't have my own lived experience in terms of having a perinatal mental health complication, but I did have the experience of like, oh, this is a whole thing and I need to pay attention and motherhood is really hard. So I started down the path of wanting to work with mothers and pregnant and postpartum folks. And so I became a doula. And so I was a birth and postpartum doula. This is 25 years ago in Chicago. And I started to find myself working mostly with families who were really struggling with mental health concerns. I had this one family that I was working with. It was a family, a very high resource family. They had every tool at their disposal. And she was experiencing pretty severe postpartum OCD. And so she had a really hard time getting out of the house and getting to the psychiatrist. And so one of the things that I would do is I would support her in getting the baby packed up, getting in the car. She could not drive at all. And I would drive her there and I would sit in the waiting room with her baby. This is a highly, highly anxious mom who then would run back and forth between her psychiatrist's office to the waiting room to check on the baby for the entire appointment. And I sat there thinking, there is something wrong with this support that this person is getting. This is not what this mom needs. This mom needs someone to have, welcome this baby into the session with her, to normalize the experience for her, to validate, and to support her, not away from her baby necessarily, but also they clearly didn't understand what was happening for her. They were not perinatal mental health specialists. And I decided to go to grad school. I was on my path to become a midwife at the time, and I decided to do a different path. And so I came up here and went to the School of Social Work in 2004.
I went to medical school to be a pediatrician, and then in interacting with the kids and their parents, I saw the strong intergenerational effect for all health conditions, particularly for mental health conditions. And so I think that is what drew me to, once I became a psychiatrist, that drew me to the field of perinatal mental health is, psychiatry can end up being a lot of crisis management and treatment of acute situations. But I think in perinatal mental health, we have the opportunity for primary prevention, and that if we support this parent, then we are preventing future mental health problems in the child. So that's what motivates me to continue to work in perinatal mental health. It's also an honor, and I'm very lucky to be able to work with families at what's a pivotal moment in their lives, and to support them. And of course, I get to meet and work with wonderful, like-minded people like the people on this panel.
Thank you. And Keshet, welcome, your response.
Yeah, so when I joined UW as a postdoc, I started in the HIV field, in the perinatal HIV field. And we were doing studies in Kenya with women living with HIV. And it kept coming up in our studies, even though we weren't focused on mental health, that women were expressing a lot of emotional distress and mental health concerns. And these were largely going unmet due to many of the factors that we've talked about: lack of services, lack of appropriate services, if services did exist, discomfort from providers and from clients in seeking care and providing care, stigma. And so it really kind of seemed like a priority to address this unmet need, and that kind of got me interested in this direction, even though I hadn't been trained in that field. And then again, I wasn't trained as a mental health provider, but I think for me personally, I find mental health work really fulfilling, because I feel like when we're working to alleviate people's emotional suffering, we're really working to support people's capacity for joy and well-being and kind of their humanity rather than just their survival. And that feels really, really meaningful and satisfying to me, of all of the things that I could be doing kind of as an epidemiologist and a global health professional. So those are the things that keep me doing it.
Great, well said, everyone. Okay, I'm gonna ask one more question, and then I'm gonna ask the audience here to think of your questions. I see that there's some coming through in the chat. So we'll do mine first, and then we'll open it up for discussion. So my question is, I would love for each of you to share a key innovation of some of your current projects and why you think this innovation has strong potential for health impact. So I will start with, I see Mary Ellen unmuted, so maybe she's chiming in.
Yes. Well, some people might not feel this is an innovation, but one of the things that's most exciting about the collaborative care model that we're implementing at Valley is this idea of empowering OB clinicians to be involved in perinatal mental health. So previously it was not really seen as part of the scope of OB or midwife practice. And so the clinicians really approach it with a great deal of trepidation. Should they prescribe? What should they prescribe? How, if they are now mandated to do this screening, what do they do when a patient's score is positive, or it can be very, very challenging for the OB clinicians. And so the opportunity, it's really different to not just be seeing patients, but to be the collaborative care model. Our care manager is a social worker who meets with the patient and identifies what the issues are, makes a plan of treatment, which often will involve some some therapy. But if it involves medication, in the case review, our psychiatric consultant, who is both a midwife and doctor of nurse practitioner in psychiatry, she will make some recommendations about prescribing, and then the OB provider becomes the prescriber. And so it really, they're learning, the OB clinicians are learning to be more comfortable with perinatal mood disorder, much more comfortable with prescribing, being able to tell patients, don't stop your medications just because you're considering pregnancy or you're newly pregnant. They're becoming educated about the incidence of relapse. And for patients, the stigma about getting care is really removed when they're trusted OB clinician that they see month after month. And then as toward the end of pregnancy, weekly, there's just a deep bond between patient and provider. And so this trusted individual is saying, I care about your mental health. It's going to have, attending to this will have an impact for you, your child, your family. Let's address this. It's really, I think, has great potential for empowering patients and clinicians and furthering this work in addressing perinatal mood disorders. So I love what I do. It's innovative because it's taking on this piece of, all these large organizations, ACOG, U.S. Preventive Services Task Force, can make these edicts from on high, but how does it translate day to day in a clinician's office? And it's exciting to be doing that.
Thank you, Mary Ellen. Let's go to Keshet next.
Thanks. So one project that I'll talk about, which I collaborate with both Mia and Amritha on, is a project here in the US where we are taking an evidence-based intervention called the Mothers and Babies Program, which has been shown in multiple clinical trials to be effective for both prevention and treatment of perinatal mood disorders. And adapting it to be delivered virtually, so in a group format. So groups of perinatal people can come together sort of asynchronously through a free app and receive the content of the Mothers and Babies program and engage with each other and ask each other questions and have conversation. And the idea of this is that delivering this virtually could overcome some of the access issues associated with in-person care and just kind of expand the reach of this intervention. So that's one of our projects. And Amritha and I also collaborate on another project in Kenya, but I'll let her talk about that.
Go to Amritha next.
Yeah, so related to the project in Kenya that Keshet was mentioning, it's similar to a lot of other projects that we're working on, which basically look at the spectrum of mental health supports that are available to individuals within the healthcare system and within the community. So the one in Kenya is within the healthcare system, where we are looking at screening and stepping up care as appropriate based on severity of symptoms, whether that's receiving therapy from a peer counselor, receiving telemedicine services from a psychiatrist. And then, but also looking at community supports and other projects like doulas or peer counselors or therapists, and just trying to bridge the gap between the healthcare system and the community support so that the individual can get the care that they need seamlessly and without any barriers.
I would add to that some of the things that we're doing. We have a really big training program at Perinatal Support Washington, training peers and community health workers and doulas. So again, really thinking about how we can augment or add to the current treatment approaches that are in place, like community mental health or mental health systems. We do a support group model where we train folks in doing a group model. We do one-to-one peer support or parent support training. So again, really thinking about how we can have a kind of a range of services available based on sort of the level of acuity, that Amritha was talking about, so that we're in some ways reserving the highest levels of care for the folks that really need it, and then giving folks option to care that again is culturally sort of appropriate, culturally attuned, culturally relevant. So we do a lot of culturally matched peer support at PS Washington. So connecting folks by racial experience, ethnic, language, so that folks can get support from folks that look like them. And then I would just say to add to that, we're working on access to those services on a policy level as well. So how can we actually operationalize peer support, at the state and, DOH, and making it so that it's something that's accessible? Because right now it's very difficult to provide peer support services. It's not a reimbursable service through Medicaid as an example. And so it's very limited in how you can provide it. So how can we think about how the systems, are working to provide the types of services that parents want?
Great, thank you all. A lot of very impactful innovations coming out of this group and your collaborators. Okay, I'm gonna turn it to the audience for questions, and I'll pick one from the audience here in person, and then we'll go to the next question from Zoom. So who's it gonna be? Go ahead. I think if you speak loudly, there's microphones in this room, so you don't need this one.
I have 2 questions.
Pick one for now, please.
So thank you for your good presentation. So the first question is among the interventions. So my first question is, among the interventions that you presented to tackle perinatal mental health disorders, which one is cost effective in low and middle income countries?
Great question. Did the online panelists hear the question well?
Yes, I think it was about cost effectiveness of these interventions. Is that right?
Yes. Keshet, do you want to respond to that first?
Sure, I'm not a health economist, but I think that I think it's been shown multiple times that that task shifting to non-specialist providers is highly cost effective. So the idea of kind of integrating mental health services into provision of other services, particularly by lay health workers, is highly cost effective. Amritha, I don't know if you wanted to add anything to that.
I'll just add that in addition to task shifting, both to lay health workers and within primary care and prenatal settings to OB providers, I think when we're thinking about the effectiveness of a treatment, it's also important to keep in mind that it be patient-centered. So while this hasn't been looked at in cost-effectiveness studies, I think it should be, that is, being able to provide a range of services to patients so they can decide what would be best suited for them, and then look at the cost effectiveness of that.
I just want to add that within the cost effectiveness, sort of like if you're, that framework is that some people get paid more and some people get paid less, which can be, I think, a challenging framework to work within, because what we see then is that lay providers or peer providers or community health workers have like a really, really low payment rate. And so we want to think about like, yes, it might be more cost effective if someone's not a doctor, right? And are we effectively paying the folks because they're, you know, even if they're not doctors or nurses or whatever credential that they may not have.
Great.
Yes,
Let's
I would
move
just
on. Oh, sorry, go ahead, Mary Ellen.
No. I would just add that cost effectiveness is very difficult to assess. One thing is that in traditional model medicine, it's a global health package. And so getting OBs, I think Amritha was alluding to this, to take the time to address these issues when it's part of their, you know, very brief mental health, very brief OB visit is challenging. But you really can't. There's at least I am not aware of a model that looks at reduction of preterm birth, reduction of low birth weight, reduction of bonding problems. It's very hard to assess these costs. Even reducing the number of visits a patient might have to the OBED for what are stress-related symptoms. These are hard things to assess economically. So.
Great. Leah's going to ask a question from online.
So the first question online is, in what ways have you observed communities filling in the gaps in care as a result of disenfranchisement regarding perinatal mental health services?
Great question. Did the online panelists hear that well? Yes. Okay.
Yeah, I mean, I think it goes back to the piece around people have been providing care to each other for well beyond that there was any, you know, credentialed or named, you know, roles. And I think that communities in a lot of ways are sort of circling back to that if those weren't there before. So I know that's happening in the Indigenous community in Washington. There's a lot of birthing justice programs that are happening, also in the Black community here in Washington. You know, and I think that folks are either going back to or reinvigorating some of the community practices that had either, you know, been systemically destroyed, right, or that had, you know, they're trying to make them more accessible if they still were there.
Anyone else from online want to chime in?
I would just say at the Marseille Society conference in Alexandria, Virginia in 2023, Mia was there. There was a beautiful presentation by an Indigenous person who was returning to her tribe the practice of supporting women, pregnant individuals through the birth process. And so I found it heartening that the group of more standard healthcare providers in the US was acknowledging the way in which these traditional individuals or practices have been disenfranchised and giving them center stage to describe that very rich culture of supporting women. So a slow return to acknowledging these practices that were marginalized.
We'll take another question from the in-person group.
And this question came in some ways from things that I've talked with my colleagues in Zimbabwe, where I do a lot of mental health work. But I think it's a global problem that often we think about perinatal mental health affecting people who are pregnant or people who have recently given birth. But where does pregnancy loss fit into this larger context of perinatal mental health? Like, do you see people who have experienced pregnancy loss as presenting with sort of similar symptoms and needing similar support to those who have recently given birth? Or is that actually like a really different population that needs a completely different set of interventions? And I think particularly that they may not be accessing care in postnatal care settings, and they need different types of support. And I think particularly in low resource contexts, that's really common. And so where do they fit into the perinatal mental health conversation?
They should be and are included in most perinatal mental health programming, individuals who've experienced perinatal loss, those who are struggling with infertility. And in fact, if you think about perinatal psychiatry, it's often thought about as reproductive psychiatry, so covering all of the hormonal epochs, if you will, like menarche and pregnancy, postpartum, perinatal loss, and infertility and perinatal loss that's fit in there. And you're right that individuals are often accessing different kinds of care or not accessing care, or might need different kinds of community support or group support, not the usual pregnancy or postpartum support programming.
I would just add that many people who experience perinatal loss have given birth, right? They haven't given birth to a live baby, or maybe they did give birth to a live baby and the baby didn't live long. So I think their experience of giving birth is different. But I think that it's a real sort of, something that we want to remember. And then also I would just agree that we want to be mindful of, not having, spaces that have babies and pregnant people and, all this happy-go-lucky family stuff in the same spaces that folks that are experiencing perinatal loss. And so I would say that within the specialization of perinatal mental health, loss is that's within it, it's not separate. And most folks that have that specialization would have comfort and training and ability to provide support.
Let's go back to an online question. Thanks, Leah.
So this question is from Kate. And they're saying, I'm curious if there are other providers in Washington State doing the collaborative care model that Mary Ellen Maccio spoke of.
Mary Ellen, did you hear the question and do you want to respond?
I did. Well, I think family physicians who provide prenatal care often have the collaborative care model within their practice, but collaborative care has been something that the AIM Center promoted. Amritha may know the dates better, but it's been at least 20 years, and initially for primary care providers. It was a way to get mental health services to underserved rural Washington. Was really one of the initial goals. So applying the collaborative care model to the perinatal population has been much more recent, and the individual who really did a lot of work in this area, and I think is a close colleague of Amritha's, was Emily Miller, who was originally at Northwestern and is currently at Brown. And interestingly, Emily is a maternal fetal medicine specialist. So a lot of the OBs who are in this work are MFMs because they see the impact of untreated perinatal mood disorder in these very high risk situations of preterm birth and low birth weight. So, but I think Emily's program at Northwestern launched in 2018. And then when I first began working with Amritha on this project in 2021, I think we were with UCSF. We were just one of 4 or 5 perinatal collaborative care programs. But at the MONA conference that Mia and I were both in attendance in the fall of 2023, there were another 5 or 6 programs. So I think the idea is really catching on that the collaborative care model is a really good model for delivering mental health care within the already existing structure of prenatal care in the United States. Now, of course, I think we do need to be mindful of some of the things Mia mentioned with, there are a lot of community providers. We couldn't do our work without Perinatal Support Washington, peer groups and the connections, their resource directory that connects patients to doulas. So there are many, many individuals out there, but just bridging that gap between ACOG and these large organizations saying OB clinicians need to be doing the work, and getting OB clinicians to do the work. Collaborative care is a great model. It's not being taught in residencies. In 2019, there was a study, 80% of OBGYN residency directors felt that their residents were unprepared to, did not have adequate training to address mood disorders in later in practice. So there's a big gap, and I hope collaborative care can help bridge that.
Great, thank you, Mary Ellen. Any more questions in the room here? I know they're lining up in the chat, but I'll toss it to the group here. Your second question? Yeah, go ahead.
Okay, this is just a philosophy question. So, are there studies establishing a link or causal relationship between the advent of cardiovascular diseases in adulthood and people born to mothers with perinatal mental health disorders?
Maybe repeat the question. So I think you're
So
asking
it's like a relationship between people born to mothers with perinatal mental health disorders and the advent of cardiovascular diseases in adulthood.
I see. Okay, linkages between a parent with perinatal mental health disorder and a child with later cardiovascular disorders.
I'm usually proven wrong when I answer this kind of question because this is a very rapidly evolving field, and once I say there's no such study, tomorrow someone will publish something, or maybe it was published last night. Or it's an interesting question though, because there are many studies of what's called the epigenetic effect of stress during pregnancy. So fetuses that are exposed in utero to maternal stress are found as they grow into childhood and young adulthood to have different kinds of health conditions. So I am personally not aware of the direct study of maternal depression and cardiovascular health, but what has been studied is different kinds of maternal stress. For example, prenatal malnutrition in the mother was found to be correlated with cardiovascular health, negative cardiovascular health in the offspring. I don't know if anyone else is aware of direct studies of this question.
I do know of some studies in progress that are looking at cortisol and stress and the beneficial effects of choline and mitigating the fetal cortisol levels. And there's been linkages between both child development later in childhood of heart problems as well as mental health problems. And there's even some question about in utero developmental linkages between the mechanisms for in utero cardiac malformations and linkages with disorders such as autism or ADHD. So there's some interesting ongoing studies, or early studies, I guess, but no results yet.
Great, thank you. I think we have time for maybe 2 more questions from the Zoom. Is that right, Mia?
Sure. I mean, we're past 4:15,
Oh,
but
okay.
but we have, if folks are okay staying, we can address a couple more questions.
Let's do one more and then people can have the mingling time.
Okay, great. Let's see, I should have taken. Sorry, there's so many. I just had invited Keshet and Mary Ellen to address some of the later questions too, if you want. Let's see. What factors do you feel are most attributable to the gaps in care for perinatal mental health services for specific communities, and what communities do you feel are most underrepresented by these services.
I think that health disparities and mental health disparities pretty much go along the same lines. So Indigenous folks and Black folks in the US experience the highest rates of access to care issues and barriers. I think that answers the question.
Right? Maybe we have time for one more.
I would just add, sorry, that I think that that also extends globally. So the same axes of power, the same disparities that lead to all the health disparities we see globally also lead to those disparities.
Right. I like Leah, there's one question in the room. Go ahead. I didn't want to hear. One question I have is, in terms of screening, whenever postpartum mothers come back, usually it's like 2 weeks, 6 weeks, 6 months. I'm just curious about how you detect or what mechanisms are available to detect postpartum mood disorders at month like 9, 10, 11, especially if you have a child that's not sleeping and with all the support is gone after the first 2-3 months, you're back at work and all these different things. I'd love to learn how screening occurs there.
I might jump in just to say that one of our goals in regular screening, so our goal in our collaborative care, well, in the group in general, is to screen at 16, 26, 36 weeks, 2 weeks postpartum if they're in for a 2-week postpartum visit, and then 6 weeks. And really, one of the biggest goals of that frequent screening is to break the taboo. And we have a DOT phrase for those of you who use Epic that says, 80% of people, I mean, theoretically, will score, they will not have a score that's flagged as concerning. And so there's a DOT phrase I encourage all our clinicians to put in that says, I'm so glad your score today looks like you're doing pretty well. Don't forget to plan for sleep and nutrition, and these problems can come up at any time. And the most important factor is tell us. So by this repetitive message, we're here, we want you to talk about it. There are many simple things that can be done to help. We hope that individuals will talk to us at 9 and 10 and 12 months. Also, pediatricians are screening, although they don't often have an access or a venue for treatment. So one of the sort of moral crises for clinicians is when you screen and then you don't know what to do with the screen. So, but pediatricians the American Academy of Pediatrics also recommends universal screening of the parent. It should be the parent who brings, or the caregiver who brings the child to the well child visit. So.
I could just add that, Keshet's point earlier was that pregnancy and sort of the immediate postpartum is a time when most folks are involved in the most systems, right, than they are in a lot of other times in their adult life. But that does taper off, right? It tapers off. And we know that 9 to 12 months is actually a time when folks are at higher risk for suicide ideation and suicidal behavior. So we really want to be thinking about who is seeing those folks. And so some of the strategies that have already been mentioned are pediatricians, but also thinking about home visitors, right? Who is still in the home, right, at 9 months to 12 months, thinking about community centers, thinking about childcare providers. And so again, when we think about sort of who is responsible for watching that parent, for providing that screening, we really think that it's anyone who's interfacing and working with, families of young children. We also know that parents of toddlers and parents of preschoolers also have a high rate of depression and anxiety that I guess parenting is stressful. So it's something that we want to be thinking about in terms of, there's lots of folks interfacing with people, with pregnant postpartum people or parents with young children, not just medical providers, right? So, who are those folks in each community, and can we get them support and training and consultation to do some, really nice connecting and resource and referral providing?
There is one last question that a couple people expressed interest on. It's about whether there's integration of elective abortion services into prenatal care clinics or primary care clinics, whether that improves mental health around these types of losses, around, I guess, losses of, elective losses.
I'm not aware of research particularly on the effects on mental health of integrating services, but I know that making these services available to people who need and want them has a positive impact on mental health.
Yeah, I would just reiterate, not being able to access a wanted abortion is a high risk for developing perinatal mental health complications.
All right, thank you so much to our wonderful panelists. And thanks to the audience in person and on Zoom. For those of us in person, there's a few more minutes to mingle and talk with those of us who are in the room and have some snacks in the back. And thanks so much to the Zoom folks as well.